And what I'm going to do now is take you away from research projects and these kinds of levels of understanding to a very situated example of an experience of this crisis. So what you see in front of you is an interface that captures a message that's received from someone. That message is in Somali. We can see that in the text there, and there's a range of different bits and pieces that you're seeing. And what you're seeing is in effect a socio-technical interface that is relevant to what I will describe later as one of the innovations we brought into this situation. And that message about coronavirus says, coronavirus has committed a huge crime against economically developed countries. It has killed leaders, rich people, and famous individuals. But it has ever been killing poor people, and no one talked about it, or the world quarantined because they are poor. And that's the message that was received. Now, what is it saying? It's saying something about the experience of something that is a threat and a panic. And here it was in, as we can see here, in May, early May, so it's relatively early on in the crisis, especially in sub-Saharan Africa. And the person is saying, well, look, coronavirus is something I know about. I know about this. It's a crisis that now worries you because it worries rich people. But we've been living under this crisis for a lot longer than you realize. It's always been killing us, but no one ever worried about it because we are poor. So coronavirus isn't a biomedical condition or fact or a disease, something that's been identified in a laboratory. It's a signifier. It signifies something that is a threat. One threat amongst many other threats as experienced, because this person is in Somalia and their life is already insecure and replete with threats they face on a daily basis. So we know a little bit more about this person. It's revealed in the top some information about them, which was gathered. And it says that this person is 39 years old in an age bracket of 36 to 54. They're from Mogadishu. They're male. They're Somali. They speak Somali as their mother tongue. The answer yes means that they identified themselves as recently displaced. So displaced, forcibly displaced from where they otherwise would live. And this is the zone and the region that they live in, Banadir, which is where Mogadishu, the capital, is. So we had this bit of information about them, but it's not enough to just have this message. Let's try and understand where this person might be. They could be here. This is a displaced persons camp in Somalia, and it's, as you can see, very ordered and structured. But actually it's not right, because I know that this camp is in Basaso, which is in the northeast of Somalia. And that's not the kind of camp that he's likely to live in if he's in Mogadishu. It's more likely that he lives in this camp, which is a far less organized and structured camp. It's more of a spontaneous displaced persons camp. And what I can tell you about Mogadishu is that a couple of years ago, it was identified as the most densely populated city in sub-Saharan Africa and the second most on the planet. And it was because of the levels of internal displacement within the country, people fleeing famine or conflict and coming to the city and living in contexts in places like this. There are 2.6 million internally displaced persons in Somalia due to those reasons. And so this is the kind of context this person is living in. And you can imagine what this kind of represents for a very virulent disease like COVID-19 in terms of transmission risk, etc. So this is a situation that this person probably finds themselves in, and in which the global public health response, thinking about Somalia, found themselves in as well. But they didn't actually quite find themselves here, because the reality is that the UN agencies and various actors who are thinking about the response in May 2020 were located in a particular part of Mogadishu. So I'll come to this in a second, but what you're seeing here is a map of Mogadishu, which is on the sea, on the Indian Ocean, and all those little red triangles are the displaced persons camps that I mentioned. So he could be in one of these IDP settlements somewhere in Mogadishu. And that is a grave concern because of the risk of high levels of transmission and, in these kinds of contexts with high morbidity, etc. But where is the response going to come from? So yeah, sorry, this is a map of Somalia and a couple of pictures of Mogadishu. I kind of want to remind you that it's both a a beautiful place and full of vibrancy, not just what you might read about in the newspapers, but it is also a place of considerable insecurity in which there is a conflict between the forces backed by the African states and Western states and Al-Shabaab, which is a militant group that is fighting for control of the state. It's also a state that's divided between different parts, including a separatist Somaliland in the northwest. But yes, so this is my big slight digression. Coming back to where the international response is coming from, because of the insecurity in Somalia and over many years, it dates back to the 1990s, there's a heightened level of anxiety amongst the international responders. And so they all occupy a space that's like a green zone, a fortified zone that's around Mogadishu International Airport. That's the airport there, and the airport is that green dot. And you can imagine a fortified zone on the sea, that small bit of land is trying to understand what's happening out there in these very many IDP settlements across the city in the context of a disease outbreak. And so the concern, of course, here is that the people who are in these buildings next to the airport runway from the UN agencies, WHO, UNICEF, etc., have very little understanding of what's happening out there and what people are thinking. And so the reversion to a classic, in a sense, biomedical response is often out of touch with the way that people are experiencing the crisis outside. So one of the things we sought to do was redress that by trying to hear and understand what communities on the ground were thinking of coronavirus in the early days. And so we collected a very many more voices, and here are a few different ones, and they give you 4 different perspectives on the crisis that we identified in early April 2020. On the top left is a woman, an internally displaced person from Dainil in Mogadishu, saying, "My opinion is to trust Allah and every difficulty will pass." On the top right, we see another young woman, much younger, who says, "Look, no, it's a dangerous disease and its only cure is prevention. Therefore, if people follow the information given by the government, I think it wouldn't have spread, and it's spreading now." This is quite a different view. On the bottom right is a young man saying coronavirus can be prevented in Somalia by expelling the non-believers. So it's outsiders and non-Muslims who are the ones who are bringing this virus, and they're the ones we should be worried about. And then finally on the bottom left, someone who's saying, well, look, no, don't worry, we should just stick to some remedies that I know well, like ginger, black pepper, and lemon, and also pray to Allah, and also practice proper hygiene, especially the IDP. So a whole array, people think many things, they don't often think one thing. But this gives you a sense of different perspectives that we understood. So how did we understand them, and what was the value of this? What we needed to do was listen to a lot of people. And what we did is we used a radio show that was already running called Imakal, Listen to Me. And we heard from over 7,700 Somalis between 3 days in April who were responding to the radio show, sharing their views on what they thought about coronavirus. And what we were able to do within about 6 or 7 days is disseminate the findings from the analysis of those perspectives. And I'll tell you a little bit more about that approach. This is an interesting methodology. It's a qualitative mixed methods methodology. People themselves are self-selecting, so one has to be careful not to generalize to the population as a whole. But if analyzed at the level of the collected or shared ideas that are held within groups, it's different to sort of counting heads in an opinion survey, a classic survey. And so it reveals group level ideas and group level beliefs rather than percentages as such. But as you can see, what we were doing was speaking to a very large number of people, getting a lot of rich text message data back in Somali, and analyzing that very quickly. And that speaks to something about the methodologies and the capabilities that we were able to develop over the recent years that are relevant to contexts like this. So I'm going to tell you a little bit more about what we found and what it revealed. One of the things that we want to identify is, what do we need to do this? We needed an already engaged audience that were receptive to this request for what they thought about coronavirus. We needed a design and a method, and we needed some core capabilities. So the first of this is that we already had the chance to engage with an audience. And that was because this Immercal Listen to Me program was running on the themes of gender equality and social inclusion, including focusing on youth, minorities, and displaced people. And Africa's Voices was running this show for the course of a year. So it became a kind of trusted radio show that people were listening to, enjoying the different segments, and then also participating in by responding to questions on a weekly basis. So every week, about 5,000 people were already responding to these shows. And it meant that we could leverage that existing trusted channel to ask them about coronavirus. And I think that's something that's quite important, which is it's not easy to quickly switch on a communication channel with a community. It needs to be there beforehand, because trust needs to already be established before you can talk about sensitive topics such as infectious disease. So Immercal was there already, and it was what was used as a basis. And that was how we quickly heard from the people we heard from. But then what we did was we brought the Immercal project into a wider response on risk communications and community engagement, using interactive mass media that Immercal allowed for, and something new which we developed in the context of the crisis this time, which is this one-to-one messaging capability. And I'm going to explain a little bit how that worked. So from the left to the right here, what we were doing was putting public service announcements out on the radio's stations, asking people to submit their answers to a question or to submit their questions to a free short code that was broadcast to millions of people. And those announcements were designed in collaboration with public health experts. And so it was trying to keep to the WHO kind of guidance and advice for how communication on the crisis should happen early on, of course, translated into Somali. And the listeners were then responding with SMS to the advertised short code. And then they were receiving demographic questions that we were collecting, as well as consent for engaging with the show. And then we were triaging that data quite quickly, and I'll show you a sense of how that worked, primarily using Somali-speaking research assistants. And what we were able to do then is respond to the questions that were being asked with standard responses that were part of a peer review protocol that had already been agreed with external actors. And where there was concerns that were escalations in terms of urgency, like someone was saying that they thought they had symptoms, or they were worried about someone else in their family, etc., we referred that to another mechanism in which there was a sort of dual oversight to ensure that they were responded to quickly within 24 hours. And as that was going on, we were able to understand how over time some of the themes and concerns of the community were changing. We were feeding that back to the radio show, so we were using the insights to shape better content that was more relevant to what people were talking about, but also feeding that back to other actors in the response. So that was the kind of overall framework that we were using. This is an interface that was used by research assistants. This is actually just one that's in Swahili from the Kenya project that was also a part of the project. And this just shows many, many messages coming in, and the way that research assistants are coding the data. And this is Zachariah, one of the research assistants at Africa's Voices, coding the data. Whether it's a question or a greeting or a statement, whether it's about knowledge or attitudes or practices, and then a question about symptoms, about how coronavirus is spread, etc. Now, this is an interface that was purpose-built with researchers in the computer science department, because we were trying to make it very simple and easy for human researchers who speak the local language to be part of the qualitative interpretation of data, rather than leaving it to automated processes. We strongly believe that this is actually much more robust than trying sort of automated processes on local language data in the Somali context or the Kenyan context. So, you know, some of the kind of examples of messages that would be received and that would be responded to on a daily basis using this workflow. So in the Somalia context, three main insights came out of the initial diagnostic. The first was that there were two very distinct worldviews. One was a call for right practice, follow government advice, follow expert advice. And the other was a focus on religious hope and practice, a kind of fatalism and a trust in God. And this was very early on in the crisis. This changed over time. But this was very important, because what we felt and we felt was very important to emphasize was that there was there was a strong interest and emphasis on interpreting a crisis through a religious framework, making sense of crisis through the value system that you hold dear. And it was very important that that was understood by the international response, because if the interpretation of it was through a religious lens, then biomedical messaging may not necessarily be immediately what people would be trusting and looking for. So that was really clear, but it was also true that there was a strong representation within the society that was looking to government and looking to expert advice. So both of those needed to be understood, not just one in that sense. The other thing was that there was a substantial amount of rumor, stigma, and misinformation, and about 12%, it was a considerable proportion of the messages that we had analyzed in that first instance in early April. So we were concerned by that, and I'll come back to that. And the second insight then was around this rumor, stigma, and misinformation. And what we found is that, of course, this is respondents who are self-selecting, but we can start to see some trends with the data because of the richness and plurality of the data. And a few things came out of this. One was that displaced people were significantly more likely to express thoughts that contain misinformation or stigma or rumor than the non-displaced. And for example, in Mogadishu, a recently displaced person was twice more likely to express this kind of concern or thought, as well as people from other insecure areas. And I think what that revealed is that people who are already at risk or who face a precarious or already vulnerable situation were more likely to be in a situation in which they distrusted certain types of sources of information and were more reliant on other kinds of information, and also more anxious and suspicious in potentially of a new threat and a new risk. So we felt it was especially important that those more vulnerable groups that we spoke about that are already densely packed into these risky settings were given much more careful attention in the way that communications with them were undertaken and who was communicating. So maybe looking, for example, to local sheikhs and religious authorities and understanding that they're more likely to be trusted. So how best to work with them to communicate with these communities that were expressing these kinds of thoughts. And the third finding was that the religious frame grew more salient for older target groups. This is not to say that age was the determinant of this, but it was just more a correlation. And that the call for right practice had a higher salience amongst younger target groups. And that this meant that differential messaging might be really valuable and focusing on different groups in different ways. So that was some of the findings we had. And what we did is we brought them back to this international response to the RCC task force, co-led by the WHO and the UN mission in Mogadishu. And we were present on a weekly basis talking about some of these insights and results alongside others. And what was really valuable was that we could see the shift in terms of certain agencies taking a much more proactive approach to engaging with the religious leaders early on to respond to the crisis. So I think it was something that we felt alongside others, not just us alone, but alongside others, was quite influential in reminding people not to just take a kind of cookie cutter approach to messaging around safe distancing, wearing masks, washing hands, etc. But thinking about who was the messenger, what was the message, what was the wider context that people were experiencing the crisis. And then we took the insights and the approach that we had developed and to other fora, including global fora in which there was discussion and knowledge sharing amongst others involved in the response worldwide. Including a group called the READY Initiative, also GORN, which is a Geneva-based initiative run out of WHO on rapid response to health crises. And so we were able to share some of the insights, but also the methodology much more widely. And actually the show itself was picked up on the World Service as an interesting way in which 30 different radio stations around Somalia were approaching and tackling the question of misinformation through the IMACAL programming, which was great to see. With the conscious of time, but I've got a little bit of time, I want to take you now to something a little bit more detailed of what we did. And so sort of the final thing I wanted to get back to. So what we see in that message that I showed you right at the beginning and this is the wider interface within which that message sits. And it's a little platform called Nook, and I'm going to tell you a little bit about that. We developed this and implemented it during the crisis. It was built up by technologists working alongside social scientists very quickly. And it's a purpose-built interface for handling SMS text messages in a way that's kind of like a conversation you might be seeing on WhatsApp, but far more sophisticated in what we can do. So here's a list of conversations, and there's 6 conversations. You won't understand any of it, but these are 6 different conversations. There's a unique identifier up here, which is an anonymized identifier of that mobile phone number. And then you see, as we said, the demographic data. And these are some labels that have been attached to this conversation that have come up during the conversation. So we see the message that we saw right at the beginning. The person is thanked for participating in Ima Calder radio show. And then they ask another question, which I think is one of the most powerful questions I ever heard at the beginning of this crisis. Between coronavirus and hunger, which is worse, right? This is not a genuine question. This is a cynical question, right? It's a sarcastic question about, you know, are you telling us this is the biggest crisis to ever affect, you know, us and the world? Well, let me tell you a lot more about the crises I experience on a daily basis. And in the context of a potential lockdown, this kind of concern was even more acute, that people were going to face much more risk and anxiety from the lockdown because of their precarious situation than from a disease that they couldn't quite see and didn't feel was in their midst. And that's the messages there. Here are some of the suggested responses. So this is the peer-reviewed protocol of different responses that we had written up and got translated into colloquial Somali based on WHO information and Ministry of Health information in Somalia. And what it meant is that someone who's operating in this space could select a message and send it in response. So we're able to handle a large volume of this kind of messages on a daily basis. But we're also able to analyze this data. And I'm going to say a little bit about that now. So that interface that you're looking at is it's new initiative that we developed out of some of the work in the last couple of years, which is not to focus on the interactive radio approach that Africa's Voices has really taken forward and led on, but to focus on one-to-one communications, and it's called Katikati, and we're just sort of working this up. It's a new sort of capability and tool that we've been introducing. And Katikati is, about one-to-one communications, maybe over SMS, certainly in the first instance, but over any other kind of channel over time as well. But what we're interested in is allowing for open communications that are conversational, and enabling conversational interactions to be part of programming response in various sectors. And it has 3 elements. The first on the left is configuring. So configuring who you want to talk to and how, and what are the things you want to be able to do with a particular group. The second is conversing with them, like you saw before, in terms of this interactive space and tracking the nature of the conversation, like who needs to be replied to, how long, how much, how out of date are we with replying according to some performance indicators like responding in 24 hours. And then comprehending, exploring the data, understanding what it's telling us about the conversation and things we're seeing. So the example I'm going to give, and I won't go into this, is a bit more detail than you need, is, and you've seen the Nook interface, so I'm not going to spend any more time on that either. The example I'm going to give is to go back to that element of rumor, stigma, and misinformation that we saw in large numbers early on in the response in Somalia. So one of the questions we were asking is, how do we address rumor, stigma, and misinformation, and also denial that that the virus exists, or that it still exists in Somalia? This became an issue, and we're talking about really tough, kind of potentially quite hostile messaging that comes, in his very extreme version of that in the message that you see in front of you, that is sort of saying, look, back off. I don't want to hear about this anymore. This is not my problem. This is your problem, right? So how do you effectively communicate in that context? When you see very large numbers of communications, you don't sort of see the fact that at an individual level, it's quite sensitive and can easily go wrong if it's not handled well. So we're quite concerned about this question, and working with others, wanted to understand what approaches might work better. So what we asked ourselves is, would a more individual conversational approach create more active engagement and lead to better message reception and possibly trust? So could we actually see if a different approach to conversing with people who express these thoughts had a better result? Because the standard approach of AVF was just to send a standard response protocol. Like if there was a message on rumor and stigma and misinformation, here's three pre-planned text messages, in a very thoughtful way, saying, you have to be careful what information you rely upon. This is the facts about coronavirus. This is what you should do. Some standard information. But we thought that's kind of rigid. It's sort of a bit abrupt, and maybe in these sensitive situations, that's not an appropriate way to go. So what we've tried to build this tool around communications to be able to do is to build it to do a lot of analytical things that are really valuable to getting programming to be more effective. So we did what's called an A/B test, which is a kind of classic experimental design test that's used in a lot of app development. For example, should the Google button be blue or gray, and they'll test it on large numbers and see what the results are, and with one group and then the other, and then they'll use that to refine and iterate, and then that's why you have such seamless experiences of technology. So that's kind of A/B test model was something we wanted to employ. So what we did is we defined these two groups and sampled them randomly based on people who were communicating rumor, stigma, or misinformation to Africa's Voices on a weekly basis. In Group A, we responded to using the peer-reviewed protocol, the standard protocol with the standard messaging. In Group B, we added conversational enhancements. So we added things that made it a bit more of a personal, engaged experience. We valued the person's voice. We asked some context-relevant questions. We primed the delivery of the peer review content in a way that said, hey, we really think you should listen to this trusted information. We asked them if they had more questions. We gave them encouragement when we closed. So we did this for the two groups, and we wanted to answer these three questions. Are people more responsive with a conversational approach? Does it sustain future engagement? Do they stay more actively engaged with the programming over time because they feel more valued? And is it more meaningful how they engage in the future? So these are the tests we had, and we ran the conversations as you saw them before with these two groups. So here's an individual as an example from Group A who answered the question about what their thoughts on coronavirus was with it's just a normal flu that won't cause any problem to people. We shouldn't worry about it. This is Group A, and this is someone from Group B says it's just a normal flu. It's not that big of a deal. Very similar message. So immediately for Group B, we greeted them. We'd like to discuss our thoughts with you. We asked them, do your friends and people who are close to you also feel that coronavirus is just a flu? And this person answers, no, they don't believe it, but I personally believe that it's just a flu. So they got an active engagement immediately. And then we said we appreciate their thoughts. It's really important to tell you what we know from trusted sources. And then we delivered the standard established response protocol on rumor, stigma, and misinformation. And meanwhile, Group A got the standard response protocol as well, right? So the Group B has got a slightly more conversational experience out of this rather than Group A. And then the next week we could see, well, did they respond to the questions that Africa's Voices asks on a weekly basis? So on the 2nd of September, the 9th of September, 16th, each week they were asking a different question. And we saw, some responsiveness in the Group B group. But of course, this is just an ad hoc example of what we were looking for. What we were able to do then is look at this across the two groups, Group A and Group B. And what we found, there's some interesting results, right? So Group A responded to our response protocol 19% of the time. They had a response back to when we send the standard messages. But Group B were being primed. So it's not like a like-for-like comparison, but they were being asked, do your friends also think this? Or what do you think of this information? So we were priming them and we were getting them, they were much more responsive. But of course we were asking questions. So that's an odd comparison. But then you might ask, well, what does that mean about what happens in the future? In the subsequent weeks when we're still talking to them, we found that Group B was twice as more engaged than Group A because we had valued their voice and been more conversational with them. So strong future engagement payoff from a more conversational approach, which suggests we should deploy and measure conversational tactics for building an active community, that building an active sense of engagement, even with 7,000 people or 10,000 people, is really important. You can't just treat them as numbers. You have to engage with them as individuals. And is the content more substantive? We found it very much to be the case. So you're not just getting more active engagement, you're getting more substantive engagement in the future as well from Group B. And that for us was really promising about what we're trying to do with Katikati, which is to enable organizations to enrich their ways that they interact and listen and value the voices of the people they're serving and build that into their programming so they get better responsiveness, they get more trust, and they can then deliver better programming and get better program results on top of that. And of course, here we're focused on rumor, stigma, and misinformation around disease and infectious disease. But you can imagine this across a range of health programming in which this kind of approach would be really valuable. And so we're really excited about where we can take all of this kind of stuff next. We also use Katikati to ask an evaluative question. So what you saw before was like behavioral data. It was not stuff that we had provoked in a sense. Whereas we did ask both groups an evaluative question, well, hey, was this conversation with you helpful? And we got answers from both Group A and Group B from a limited amount of response. They both responded about 30 to 36% of both groups responded to the question at all. But we did see, while there was positive evaluation amongst both groups, it was more pronounced in Group B with less negative evaluation. This is just preliminary results. We need to still run some statistical testing of this as well. But it gave us enough as a pilot of a strong hypothesis that the more conversational approach is really valuable. So we're quite excited about what we can do with this new innovation and its use. And that's something I want to end on there. So yeah, I want to open it up at this point to question and answers, and also say that if some of you are interested in health communications and public health and in kind of the application of new communication technologies in this kind of space, then yeah, talk to me. Over to you, Rahul. Thank you.
Thank you very much, Dr. Srinivasan, for that really interesting talk. It's kind of some of the highlights that I personally found from it. I love like the actual responses from the people that you shared. I think that made it like really interesting, hearing from them that they're real people, and the fact that trust needs to be established before the response, which is with the radio station and its existing network. I think that's something that in the UK and in other Western countries that there's an implications for that with messaging there too, definitely. I've got a question to start off with, if no one else does it while I'm asking, whilst Dr. Srinivasan is answering. Maybe if you want to put something in the chat. But I was wondering about the role of religion as a whole, because Somalia obviously is a far more religious society than the UK. And do you think that overall that makes public healthcare messaging and biomedical messaging in general about a pandemic more difficult, or does it actually provide more of an opportunity to make it more effective?
Yeah, it's a good question. So, I mean, obviously the answer is it depends. That's the usual answer to this. I think that in some respects it makes it less difficult because you have a very clear structure within which to work. It's in a sense a very dominant and to some extent singular structure. So the vast majority of the population is religious and will be going to the mosque on a weekly basis, will be listening attentively to what their religious leaders are telling them, as well as other leaders. But that's going to be a very important way in which they make sense of their world. And I guess that's the point I would sort of start by saying, is that what's going on is not religion alone or per se. It's actually that in the moment of crisis, you turn to things you can trust and sources of guidance that you can trust. And if that is Google for you, or a Facebook group that has QAnon kind of content, or if it's your family members or expert authorities or the government or Chris Whitty, or people have very different places they go to and turn to as sources of information they can trust. And so in that sense, I would just treat religious institutions as one amongst many. So the good thing in this context, of course, is then that there is an ordered, structured, hierarchical, institutional form that you can engage with. So engaging with religious leaders by the government doing that could be done in a very coherent way, although there is a reasonable amount of diversity amongst different religious leaders as well. And so once it was understood that that was crucially important, it could be acted upon pretty clearly, and it was, I think, reasonably effective. What it makes it difficult and challenging, perhaps, but whether that's more or less challenging than some of the other ones that we face in our part of the world, is that it's not just a channel, right? It's not just a means to an end. You can't treat religious leaders or religious institutions as a means to an end. The mediation of the biomedical or public health messaging is going to happen. And so it's a negotiation around what things are a priority. So one of the challenges that was facing Somalia relatively early on is that there was a banning on gathering in public places, but it was also very soon going to be Ramadan. And so you have these two worlds colliding. And so one of the big anxieties expressed by religious leaders is that the government, which is not the most trusted government in the world for some obvious reasons, if you know politics in that part of the world, is now sort of trampling on our religious, institutions and values and practices. So it was a very sensitive period in which it was considered extremely important to reduce gatherings in public places and maintain social distancing, but it had to be handled. It had to be negotiated. It was not just a matter of convincing religious authorities to follow WHO practices and espouse, those practices, but actually trying to work out what was possible so that they were kept on side, and that meant a bit of give and take. I think that was probably quite important. So I guess, yeah, I think a bit of more easy and a bit less easy as well.
Yeah, thanks very much for that answer. I think a question that's come in as well, so obviously you had to kind of do all this work pretty soon. I mean, you had the experience with Ebola, but pretty soon after COVID-19 hit the world, you had to go in and use all this on the ground quickly. Do you have any kind of plans in place now for similar messaging systems or similar engagement strategies if we find a vaccine, for example, or a potential cure? And what do you think the challenges are of something like that being received in these communities?
Yeah, it's a really good question. I think that's something no one's given enough attention to. It's starting to be given a bit more attention now. There's some really good work being done at a global level around bringing the Gavi, the Global Alliance on Vaccines and Immunizations, a lot of experience in this area, a lot more front and center of thinking about this challenge. I'd done some work a few years ago with UNICEF in Somalia around polio vaccinations. So very close to eradication and now eradicated, but it was that last crucial sort of period of eradication in Somalia. And it was really interesting. We were using the interactive radio shows to understand community perceptions of risk and how that affected practices around vaccination. And this is a bit of a digression, but what we found, which I thought was really interesting, was that people, especially in rural areas, but not only, who thought that children in their community were at less risk of polio, were less likely, if they were parents, to have vaccinated their child, but also less likely to have vaccinated them for measles or anything else as well. So it was a risk perception that was driving this. And the reasons why the perception of risk was lower was because people felt that, look, we live in the rural countryside. This is a disease that affects people in the cities. Here the air is clean and we are devout and we follow religion. And so the polio, the name was a colloquial name for it, was, and I forgot the name right now, but it basically meant like a bad wind. So as something that traveled in the wind, it was a bad wind, it was a foul wind. So it was dirty, it was polluted. It happened in the city and it happened amongst non-believers or people who were not devout enough. So one of the things that was very important with the vaccination was to bring it as not, as something that had to not contrast with the idea that, look, if I'm living a pure and life or devout life and I'm in good environment, that the vaccine isn't contradictory to that, because why would I allow my children to be vaccinated if I really believe that? So again, working with religious leaders and community leaders around that kind of messaging was important. And all of that to say that, yeah, there is no automatic receptivity to vaccines, and there never has been, and there won't be in this country, and there won't be in other parts of the world. And so this becomes, yeah, a really important way to it's around social norms and values, and how to create a discussion space that's trusted, that surfaces the sorts of anxieties that people have or the misconceptions they have, and surfaces them and works through them with trusted sources and people that they will trust, rather than talking down to people. It often involves bringing people like them into the discussion and allowing them to explain why, I did this and I really think it's the right thing, or whatever it might be. But the narratives that allow people that are much more likely to be the things that they trust, rather than a person in a white coat telling them that they must have this vaccination. So media becomes extremely powerful and extremely valuable as a way of creating the kinds of discussion that is an enabler for receptivity towards vaccination. So yeah, I mean, certainly the Africa's Voices team will be working on that in the Kenya and Somalia context as a start.
Great, thank you. Another question that's come in on the chat. So outside of pandemics, for long-term public health communication, how can frameworks be put in place to move public understanding away from misconceptions spread by local sources to scientific information grounded in evidence? So long-term public health communication, what frameworks can we put in place for this?
Yeah, I mean, that's not an area I work on too much, but of course, I think it's a huge question. I mean, the problem, of course, is that things are going backwards in our part of the world as much as anywhere else, and so the aversion or suspicion towards expert and scientific knowledge is one of the ways. It's a dominant frame through which contemporary politics is being expressed at the moment. So there's a whole side of partisan politics that is represented by that kind of view and is able to trigger it and instrumentalize it. So I wish I had the answers here. I think that communications is really important, and there's lots of work that can be done around making scientific information and knowledge accessible and trustworthy and meaningful to people using mass communications. So I think that's definitely part of the need and the challenge. But I dare say that most of this is around education and the education system, because if you don't get that sort of understanding and trust and appreciation of scientific knowledge established early on and really in a really strong way, it's going to be always harder to do it through some kind of media, engagement, in which at a later stage, when you have so many other contending narratives that are very artfully and tactically developed to push another agenda. So yeah, I mean, one of the things I would say here is that the right side of politics and progress and justice as such is probably sometimes a bit too high-minded. As if it should be taken as incontrovertible fact that people should think X or they should think Y. And the other side of this equation is far more attuned to the sentiments and the anxieties and fears and vulnerabilities and suspicions of people, in all sort of aspects of their lives, and is able to instrumentalize that tactically using communications. So communications is a really, really powerful and important tool, and the sort of what we might think of as the noble and good side of this equation is really bad at it, because it's too sort of self-assured of what is right and good, and thinks it stands to reason that drinking some kind of sanitizer is a bad thing, or that the economic impacts of a certain decision on the country is a bad thing. Like, it's as if it's this foregone conclusion, but actually that's not how people experience or live their lives, and they have a lot of distrust over what things people think are foregone conclusions. So a bit of humility and a bit of understanding that communications is very important to get tactically right is part of what's needed.
Great, yeah, 100%. Just a few last questions. From Atka, I particularly liked what you said about building active communities. Have you done much work or know about work done regarding communication in commune style setups?
I guess it would be great if that person could clarify what they mean by commune style setups, so what they were uh, interested in. But I will, yeah, if they are writing, great, you can come back. I mean, I've got one interpretation of what that question is about, and if it's true, one of the things that really interests me is that we need to create, we can use technologies again to recreate the spaces in which people interact and create ideas between them. So one of the things I'm really interested in is not just this sort of messaging that's from a center to, to people in a community, but actually what are the ways that, and this is something I work with computer scientists on, is we assume that technology is pretty bad for democracy right now, or digital technology, because we take Facebook and Twitter and we look at some of the things that it's, some of the trouble it's causing us. But I think what we're not really asking enough, and we think then we need to deal with that with privacy or antitrust legislation, etc. That's all important. But one of the things I think we're not asking enough is, if we were to rethink what we can do with technology around the kinds of spaces of collective discussion and collective action that we would think is valuable in the world, what would that look like? How would we design these technologies? So one of the things I'm interested in is socio-technical design. So how do you take values you care about and relate them to technology design in ways that are fruitful? And it becomes really interesting then to think of collective spaces like communes or for like social movements, etc., and how we can create much more enabling technologies. They don't have to use Facebook to gather and yet be part of an extractive, surveillance capitalism in order to gather around a social cause. So we need to come up with other ways of making those sorts of progressive agendas possible.
Great. Yeah. And just the last question, I think it's a nice one to finish off. Where could these findings that you and your nonprofit have created or have found, where could they be applied next? Are there any locations in the world that you believe are particularly in need of this, apart from in East Africa? And I guess, does the foundation have any plans for other regions or other countries?
Yeah, big question, really interesting one. So when I originally did the research that led to the establishment of the foundation, had big ambitions and ideas of how we can make this method, and also just make it available to others to use themselves rather than just this organization. It all became a lot more complicated than that for a bunch of some boring reasons and some important ones. But one of the ones I think is that well, there's two reasons, I think. One, that the organization itself couldn't work in very many countries very quickly. It's just really challenging. And it's a charitable organization, and I found that actually a really challenging model to grow. You just spend a lot of time trying to survive rather than grow. So that was difficult. And the other thing we learned is that the methodology needs to be applied with a lot of care. And so we needed to make sure that if it was being used by others, we came up with really strong ways to advise a protocol for its use and deployment. So those two things have held it back a bit, but we've come a long way. And I think if I had an idea in the next couple of years, what I think we're very close to being able to do is to make the methodology and some of the tools that make it possible for others to deploy it to be more publicly available. And one of the things that very recently we did an evaluation and wrote up an evaluation of the method and a protocol for it that's being published in a leading mixed methods journal. And so that will enable the methodology itself to get out to other researchers. That's on the one hand. And the other thing is to continue to build these tools that are, some of them that are sort of open source, and that there's an applied protocol that attaches to them that allows other organizations to take it forward. So certainly in sub-Saharan Africa, it's still the case that radio is really, really powerful medium to reach many, many people, because it's also local language, which is really important and accessible. And so I think at least the very least in a continent that is super important to the near future, it would be great to see the method expanded with this work that's being planned in Uganda and Ethiopia at the moment as well. So that's a start. Fantastic.
No, great. Thank you so much. That all sounds really promising and exciting as well. Thank you very much overall for such an insightful talk. And this is work that's happening in Cambridge. This is research that's being done in the colleges and buildings around all of us at the moment, being applied on the ground in the field to help developing countries fight the same fight that we're all fighting.